Welcome to our chronic kidney disease educational class. My name is Britton Hart. I'm one of the nephrology nurse practitioners with Diablo Nephrology. Thank you for coming today to this very important class. One of my goals today that I really want you to get out of this session is for you to be an active participant in your health care, really become a partner with your nephrologist and your providers, advocate for your health care. I'm going to provide you some of that basis knowledge today, and we're lucky enough to have many experts in their field of chronic kidney disease that are going to share all kinds of knowledge with you today. I would like to start off first by going over a brief agenda for today. First, we're going to have an overview of chronic kidney disease with me, Britton Hart. Then we're going to move into a discussion of medications with our pharmacist, Jamie. After that, we're going to have a dietary discussions of CKD with our dietitian, Amy. Then we'll move into a briefing of dialysis options with our home therapies nurse, Rose. Lastly, we're going to have an outline of transplant with our renal transplant coordinator, Kelly. So first, let's just get started. Let's get really basic. What are the kidneys? So the kidneys are two bean-shaped organs about the size of your fist. They lie on the opposite sides of your spine below your rib cage. What do? So they work to filter blood to produce urine, composed of waste products and extra fluid. More things they do. Okay, so besides building up and preventing waste and fluid in the body, they help to keep your electrolytes stable. They're very important in regulating blood pressure, making red blood cells, and they're very important for bone health. So what is chronic kidney disease then? So chronic kidney disease is when your kidneys begin to lose function to support maintaining body health. You may start having issues with your blood pressure, electrolyte balances, and problems in bone health. So overall in the United States, 14% of the US population has chronic kidney disease. So you are definitely not alone in your journey. What causes chronic kidney disease? The number one cause in the United States is diabetes, followed by high blood pressure. Sometimes it can be caused by inherited disorders, medications, drugs, autoimmune diseases. But by far and large, it's really diabetes, uncontrolled diabetes, and uncontrolled high blood pressure. When you go to your provider, we ask for a lot of blood. I want you to pay attention to a few blood tests that we do and really know what they mean so you can have a conversation with your provider when you go to the office and really begin that partnership and that advocacy for yourself. So the first test we look at is creatinine. So what's creatinine? So creatinine is the normal breakdown of muscle in the body. As creatinine is built up, okay, it's filtered by the kidney and excreted in the urine. When you have impaired kidney function, the creatinine starts to build up. Okay, so the higher the creatinine level in the blood means more impaired kidney function you have. So when you go to your doctor's office, you want to know what your creatinine is. Your goal is to keep your creatinine better or the same. We also look for a test called GFR. So GFR stands for glomerular filtration rate. We use that to stage kidney disease. So you may often go to your doctor and they say, hey, you have stage 2 kidney disease, you have stage 3, you have stage 4. What does that mean? So a picture really says 1,000 words here. So stage 1 kidney disease, you have most of your kidney functioning, the blue part, 90 to 100%. And as you advance and kidneys get more slow and more impaired function, you start to lose more. Stage 3, you have 59 to 45%. Stage 4, you're functioning here 29 to 15%. All the way to stage 5, where you have less than 15% of your kidney functioning. And when you get down to this area, you really need a renal replacement therapy, dialysis, transplantation. The kidney at this point is not healthy enough to maintain health, so you need some help. Once again, the goal when you go to the doctor for your GFR is you want to keep it the same. Sometimes it will be a little better. Okay, so creatinine, you want it the same, GFR the same. Keep track. It's important to keep track of your numbers. The second test that we look at, and it's very important, is we look for protein in your urine. So inside a healthy kidney, you see here, protein's not leaking through. There's no protein in there. When you have a damaged kidney, protein is starting to leak through there. So the more protein you have, the more damage. So you want to know, you want to keep track and say, Doc, listen, how much protein do I have this time around? Are things looking better? Are they looking worse? Is there anything I can do to help this? So kidney disease is often progressive. It's a progressive disorder. But there are things that you can do to help prevent progression. So the ball really is in your court. Okay, I want you to feel empowered too in this session. I want you to become an active participant, like I said, a partner, and really feel empowered that you have a difference to make in your health care. So let's talk about some of the things that you can do to help prevent the progression of kidney disease. The number one, control your blood pressure. We really want your blood pressure less than 130 over 80. You can do that by controlling the amount of salt intake. We really recommend less than 2,000 milligrams or 2 grams of salt a day. Quit smoking if you smoke. Getting enough sleep, and it's very important to take your medications as prescribed. So what else can you do? Number two, meet your blood glucose goals if you have diabetes. So very important if you are a primary care doctor, if you have an endocrinologist that follows your blood sugars, keep your appointments, stay on top of those things, making sure you get your hemoglobin A1C test. Most important, we like your hemoglobin A1C usually less than 7%. So having really good control of the diabetes will help prevent progression of your kidney disease. Thirdly, stop smoking. So we all know smoking's not good for many reasons. Well, it's not good for the kidneys either. It's not good for the heart. It can increase your blood pressure, increase your chances of heart attack and stroke. If you're interested in learning more about smoking cessation, smokefree.gov is full of excellent resources for this. Exercise. We all know to exercise. Really try to be active for 30 more minutes a day on most days of the week. Physical activity helps reduce stress, manage weight, achieve your blood pressure goals, and your blood glucose goals. Get enough sleep. Who gets enough sleep in here? One of the hardest things to do, 7 or 8 hours a day. And like I said, for all things about, why physical activity is important, same thing here. Good for your mental health, help you reach your blood pressure goals and your blood sugar goals. Taking medications as prescribed, very important. Also very important to keep an updated med list and bring it to every doctor's appointment that you have, because things seem to be constantly changing and your doctor really needs to know what you're on. It's important in kidney disease because if kidney disease progresses, we may need to change a medication adjustment or sometimes just stop it altogether. So very important to keep that med list updated. I know Jamie will talk about this in her pharmacist section, but it's so important, I think it warrants mentioning again. Be careful of a class of medication called NSAIDs. It stands for non-steroidal anti-inflammatory drugs. They go by the names of ibuprofen, Advil, Aleve, Motrin, naproxen. They can hurt the kidneys. They can cause high blood pressure. And you can see, if you look, I have an example here. If you look on the drug facts label, it will say NSAID right there in parentheses. You see that, you know right away to avoid it. And last point I have, as if you have kidney disease, you're more likely to get heart disease. They share the common problems of high blood pressure and diabetes will predispose you to heart disease. So heart disease is really any problem that prevents the heart from pumping well. It may be in your blood vessels or in your heart. Heart disease is the #1 cause of death among people with kidney disease. So I want you to make sure you're following up with your primary care doctor or your cardiologist if you have one, to make sure that you're up to date on all your heart function tests. And that is all for my section. We will move on to the next section in a moment. Thank you.
My name's Amy. I'm a registered dietitian. I've been a dietitian for 27 years. I work in the dialysis field, and I want to just go over the nutrition end of this program. So we're going to pretend like we're in a grocery store, and we either can go to the shopping cart or the shelf, depending on the items in here. And we're just going to cover kind of the principles of the diet, a nutrition diet, in a nutshell. So the first thing I'm going to talk about is albumin, which is a protein in the blood. It's the measurement of how much protein's in your blood. And I was wondering if anyone knew what a protein was. Any protein items? Meat. Protein is really important in the diet. So I would encourage a lot of protein. And meat. Would you consider hamburger meat? Mm-hmm. Okay. Do you think if we're talking about having protein in the diet, a hamburger would go in your shopping cart or on the shelf?
Shopping cart.
Okay. It does, because the meat in the hamburger is a good source of protein. If you're diabetic, we can talk that a little differently, because there's the bun, which has the carbohydrates, but we're just talking kind of the meat category right now. So I would definitely put this in the shopping cart. Any other protein items? Chicken. And where's my chicken? Here he is. Chicken's a great source of protein, so I would definitely put this in the shopping cart. So all the information I'm going over is in handouts that you're going to be receiving, so it's just kind of an interactive display that we can go on with. Any other items that are protein items? Or I'll pick. Do you think hot dog's protein?
Yeah.
Okay, so correct. It's a protein. It's probably not your best protein. Does anyone have an idea why it might not be your best protein? High salt. So that's another category we're going to talk about. What happens when you eat a lot of salt?
You get swollen?
Swollen. You get pretty thirsty. It has a lot of salt in it. So a lot of salt makes you thirsty, retain water. A lot of people in this stage of their kidney disease have issues with retention of water. So do you think hot dogs would go on your shelf or in the cart? Shelf, okay. And I'm going to come back to this hot dog in a minute, because not only does it have protein and it's high in sodium, it's also high in another mineral, but we're going to come back to that because I want to just touch upon a few other salty items. Anything else on this board that you think might be high in salt? Pizza. And why do you think that's high in salt?
It has, I don't know, pepperoni?
Yeah. So cured meats and cheese have a lot of salt in it also. And we're going to come back to this item too, because it's going to go along with the hot dog. So shopping cart or shelf? Okay. For a few different reasons. I want to touch upon the sodium content in canned vegetables. If fresh is always best, frozen's always good, and canned, if that's the only resource you can have, would be fine. The way to get rid of some of the sodium content in the can would be to rinse it in a colander a few times, and then you'll reduce the sodium. So I'm going to put canned peas in my shopping cart because you can rinse some of the sodium from them. If you were to be on dialysis, you have a dietitian on staff that will go through all of this in much more great detail, but we were just kind of outlining some of the big key factors, and sodium is one of them. Most people ask how much sodium they should take in. I probably would stay about a 2,500 milligram diet. If you end up going to dialysis, they're going to restrict it a little bit more, but I would say on an average about 2,500 milligrams or 2.5 grams. The next one we're going to talk about is a mineral called phosphorus, and it relates to how your bone turnover. It also correlates a lot with calcium. Phosphorus is tricky because it's a mineral that you find in absolutely everything. So it's found naturally in products, which is your organic source, and it's found inorganically in products, which is your unnatural source. So a lot of the food items that we encourage people to eat will have phosphorus in there naturally, but a lot of the food items have phosphorus added to it. So that's why I want to go back to our hot dog, which would be a perfect source. The color of a hot dog is not a real natural color, would you agree? Anything that's high in preservatives is going to be high in phosphorus. So anything that doesn't look natural, is not natural, is high in phosphorus, should stay on the shelf. So it's high in sodium and phosphorus, so that's the reason we're putting it on the shelf. What about mac and cheese? Do you think this is a natural source? No. Okay. You can make mac and cheese from scratch with cheese, but anything that can sit on the shelf that has a shelf life of 10 years is not natural, and it's going to have a lot of phosphorus in it. So you really want to be careful on things that aren't on their natural form. So you could have cheese, but mac and cheese from a box. So I would put cheese in the shopping cart, and I would put mac and cheese in a box on the shelf where you picked it up from in the first place. Phosphorus items. Anyone else? You're going to find phosphorus in the category of milk and milk products. Nuts, milk and milk products and nuts are your main categories of phosphorus, and then anything that kind of falls in there. So anyone can see anything on the board that you think might be high in phosphorus? Milk. Okay. So milk does have phosphorus in it. It also has another mineral that we're going to talk about in a minute. It's also a fluid. You are allowed milk on a renal, pre-renal diet. You need to limit the amount of milk you want to have. So you could have milk or you could have cheese, but it's hard to have both. So if you're a real milk lover, then we're going to have the milk and we'll put the cheese on the shelf. If you're a real cheese lover, we'll have cheese on the shopping cart and milk on the shelf, okay? Milk does have phosphorus, but you're allowed it. So knowing that information, where might you put milk? Okay, so cheese and milk are going to go on the shopping cart. And we're going to come back and kind of summarize everything because we're going to kind of lump it all together. Anything else that you think might have phosphorus in it on this board? Crackers. Crackers definitely are a baked item. They sit on a shelf. They have a very long expiration. Anything that tastes good usually has sugar or sodium in it, because phosphorus is not only a preservative, it's also a flavor enhancer. That's why it's a double whammy, because you get it naturally, and then to make something taste really good and to preserve it on the shelf, you have phosphorus, phosphorus, and phosphorus, okay? So crackers are allowable, but you have to kind of monitor how much you're going to do. So I think we'll put them in the shopping cart, but you also want to make sure that maybe they're the unsalted type of crackers and the type that are lower in phosphorus. The other category we're going to talk about is potassium, and that's the mineral that controls your heart rhythm. So too high or too low can have irregulars in your heart rhythm. Potassium generally falls in your fruit and vegetable category. that's your umbrella. So there are some fruits and vegetables that are lower in potassium and there's some in higher. And what I think I want to point out is this is like a shopping trip excursion, and there are a lot of foods you can have. We are just kind of summarizing it onto the ones that you may want to steer away from, but we can also talk about all the wonderful foods you can have. So fruits and vegetable category, anyone know what a high potassium fruit might be? Yes. So banana is really concentrated in potassium. If you're eating bananas now and you kind of want to prepare yourself for, down the road where you're going to be going, I probably would start to limit the amount of bananas. So if you're eating one every day, I might try to cut back to a half of one every day, and then a half of one every other day, and then maybe keep it at that for a while. Not making any big drastic changes, but a little bit here and there, but definitely high. So where do you think this would go? Shelf, okay. What else do you think is a potassium category? Orange juice is a great, where is it? Right here. So yes, let me ask you this question. If you had an orange juice or an orange, any idea which one would be higher in potassium?
Orange juice.
Orange juice, and why do you say that?
Because you need a lot of oranges to make all that orange juice.
Right, so if you can think about how many oranges you need to squeeze to make the amount of orange juice you want to drink to be satisfied, it's a lot. So you can have a very concentrated source. So that's the same with dried fruit versus the whole fruit. The whole fruit has the water content. When you dry it out, it's very, very concentrated. So you can actually have less of the dried versus the whole. Same with the juice. I would go with the with the whole source versus the juice. Now, we're just picking out orange juice because it's high in potassium. There are many juices you can have. You can have apple juice, you can have cranberry juice, you can have grape juice. We're just kind of talking potassium here. So where would you put orange juice?
On the shelf.
Yeah. And where do you think oranges would go?
Shelf.
I'm
Moderation.
going to put them on the shelf because you can have a little bit, but they're kind of in the category with the bananas. They're a higher source. But cucumbers are a very low source of potassium. Broccoli, apples, bell peppers, cauliflower. So these are all things that could go in the shopping cart that are have potassium in it, but they're on the lower end of it. So as you can see, our shopping cart's kind of getting fuller and it's getting colorful, and you can kind of see that there are a lot of things you can pick from. Coming back to, let me ask you this question. What do you think potato is? Fruit or a vegetable? Vegetable. Do you think potassium? The potato has potassium. What do you think French fries are made out of? Potatoes. What else do you think French fries have on them?
Salt.
And what else do you think? Do you think that the French fries are really that do they look the same color? So what do you think makes them taste so good?
Phosphorus.
So phosphorus is a flavor enhancer. So I don't know anyone that doesn't think a French fry tastes good, especially probably the ones that come from the red box. So they are, where do you think these would go? Yeah, I would say you can put them on the shelf. However, if you have to have French fries, instead of getting the supersized ones, I would probably get the small and eat them, or I'd get the small and share them. So if you have to have them, then you can do that. But if you're gonna get the supersize, then I would put them on the shelf. And they're very high in sodium, which is gonna make you swollen, which is gonna make you thirsty, which is gonna make some of your fluid retention a little harder. There is a trick to potatoes. They are very high in potassium, but if you have to have a potato, you can it's called leaching the potatoes. And basically you slice the potato, you put it in water, and it leaches some of the potassium. And then you dump the water, and then you repeat the process again, and then you dump the water again, and then that makes, you usually remove about half of the potassium. However, that being said, I don't know many people that if they want a baked potato and you do that whole process, I don't think your baked potato is going to turn out the same. So a potato is one of your higher potassium foods, so shelf or cart. Yeah. However, you still have like the bell peppers we were talking about, strawberries. These can all still go in the shopping cart. So once again, I just kind of want to reiterate, there's a lot of food choices you can make in your shopping cart.
What about grapes? I heard they're really high in sugar.
So grapes, okay, so here's an interesting thing. Grapes are potassium, they're low in potassium. So if you're just speaking about potassium, I would stick them in the shopping cart. But then a lot of people have diabetes, which raise the blood sugar. So if we're talking like an overall diet and we're not specifying diabetes or chronic kidney disease, then I would say grapes go in the shopping cart. But once you're there, and if you actually have diabetes and you're checking your blood sugars and it's really high, then yes, grapes are a little high in sugar. So I'm gonna leave them in the grocery store. And then while you're shopping, you get to decide, depending on what your health issues are, where this comes or goes. Speaking about fruit, same with fruit as with the canned vegetables, canned fruit. If you can't get the fresh fruit and you can't get the frozen, you have to get canned. You want to look for canned fruit that's low in sugar, so it's not in the high corn syrup sugar. If you can't find them packed in water, you try to go to natural juice. If you can't find the natural juice and you have to do the sugar, you want to just make sure you rinse the fruit a few times in the colander. So I would definitely put fruit in the shopping cart, even if it's a heavy syrup fruit, because you want to rinse it and go from there. So that goes in the shopping cart. So you have like a sliced tomato. What category do you think tomato would be in? Potassium, because it's a fruit and vegetable. So you can have some tomatoes, but I wouldn't, during the summer I see people, the tomatoes are really in season and people are just like eating them off the bushes and hundreds of cherry tomatoes. You don't want to do that. But if you love tomatoes and you want a little slice of a tomato to put on your burger, then that's definitely fine. You do need to be aware of, how much potassium you're eating, but definitely I would put tomatoes in the shopping cart.
What about eggs? Are they good for you or not?
Eggs are fabulous. Eggs are great. Eggs got a really bad rap a few years ago. I think what you need to remember is whatever information you're collecting, whatever information you're getting, whoever you're getting it from, you want to make sure you read who's sponsoring the material that you're getting. So if it's, the egg board, they're going to promote eggs. If it's someone else, they're going to not promote eggs. If you're talking about a protein and how to measure a protein, an egg is a perfect source. One egg is equivalent to 1 ounce. Okay, so the weight of it is 1 ounce, and 1 ounce of protein is 7 grams. So it could be 1 egg is equivalent to 1 ounce of chicken or 1 ounce of your beef patty. Now most beef patties don't come in 1 ounces, they're like 3 or 4. But if you're talking ounce for ounce, equivalent for equivalent, an egg is 1 ounce and it's a great source of protein. So I encourage a lot of eggs. And if you have high cholesterol, you can always take, if you have like 2 eggs, you can take 1 yolk out. If you're going to make like a scrambled egg or an omelet, you can use 2 egg whites and 1 egg yolk, or you can take the yolks out completely and just use the egg whites. They also have like egg whites already made up in the grocery store if that's too much. But this is a definite yes, this is a great one. So I think that's just kind of an overview. I think what I really wanted to stress is that this is kind of like a life choice. There's a lot of choices that you can make. There are some items that probably should remain on the shelf, but if you have to have them, you can kind of manipulate around. You can always meet with a dietitian. Definitely if you're starting dialysis, there's a dietitian on staff in the clinic at all times. Or if you meet with your doctor and the doctor's talking to you about nutrition and you want a little bit more information, ask your doctor who can you speak to. They might have a dietitian on staff, or they might be, your insurance might cover some nutritional counseling. So I would definitely, this is just an overview. It's kind of a generalized, everything's in a packet, and any other information if you're looking for that we can provide for you. Thank you.
My name is Jamie Kumasaka, and I work as a pharmacist at a local Bay Area hospital, and I have been a pharmacist for about 15 years. Today I'm going to talk to you about pharmacy take-home points, specifically about your medications and some pointers and reminders in the setting of having chronic kidney disease. As a pharmacist, I actually work with your physician, dietitian, social workers. We all work as a team together in your healthcare. Today I'm actually going to talk to you about taking your medications as your doctor has prescribed, as well as maintaining a good medication list for yourself. And lastly, I'll talk to you about vaccinations towards the end of my talk and the importance of that. Normally, when we take medications, as you can see here, we ingest the medication, it goes into our body, and normally these are our two kidneys, and we have normal blood flow going to our kidneys, where our kidneys actually filter or help process the medication in our body. Unfortunately, when you have kidney insufficiency or chronic kidney disease, as you can see with these hashtag lines here, you actually have some decreased blood flow to your kidneys, and we'll focus a little bit on that. And sometimes your medications may need to be dose adjusted, so we give you less medication, or we may need to alter your therapy or modify it where we have to avoid certain medications. In general, I'm going to be talking about medications in chronic kidney disease. Everyone may be at a different stage in terms of where you may be at with stage 1, 2, 3, or 4, or 5. Maybe you're already on hemodialysis, or maybe you're not, or peritoneal dialysis. But in general, my talk is going to be talking about medication management throughout all the different stages. So in the beginning here, I want to talk about medications that we want to avoid or use with caution. And the first one is what we consider, or what we call non-steroidal anti-inflammatory drugs. The abbreviation for that is called NSAIDs, the NSAIDs. The reason why we want to avoid the NSAIDs is they can actually reduce blood flow to the kidneys, and they can also raise your blood pressure, which we do not want. NSAIDs, or non-steroidal anti-inflammatory drugs, are provided over the counter, which means that you could just buy them from the local drugstore. You do not need a prescription for them. Some examples of NSAIDs include the list here. So ibuprofen is one. The brand name or names that you may be familiar with is Advil or Motrin. It's the same thing as ibuprofen, it's an NSAID, as well as naproxen, or the brand name for that is Aleve. Prescription examples include celecoxib, or the brand name is Celebrex. That's often used for some arthritis pain. And in the hospital, we also use another medication called ketorolac, or the brand name for that is Toradol. One thing I'd like to point out in terms of NSAID use is because you could just get this without a prescription, it's really important to pick up the medication box and read all the active ingredients in there. So this is an example of a product that you could get from your local drugstore. It's Advil Codeine Sinus, and the active ingredients are listed here. So it actually includes the ibuprofen as well as the pseudoephedrine in there. So you may think that you're just buying a cold and sinus medication, but it actually has the ibuprofen or NSAID within each tablet. If you ever have questions about what you're buying, maybe for a cough and cold, or flu or fever that you may have, it's always a good idea to talk to your pharmacist at the local drugstore that you're at to make sure if there's any NSAIDs in the product you're looking for. And remind them that you have renal insufficiency or chronic kidney disease, and if the product would be safe for you. The other class or topic of medications I like to talk about is herbals and supplements. So I have a list here that's going to be included in your packet or a handout. And what it includes is some herbal supplements that actually may contain potassium and phosphorus that may not be good for you with your chronic kidney disease. And so this handout goes over a list of herbal supplements that contain both potassium and phosphorus, and ones to avoid or use with caution. So maybe you could have a little bit of it, but not excessive amounts. So examples here, again, it's listed in your handout as well, are some of the herbals with potassium, some of them with phosphorus listed there, and then the list of ones to avoid as well are there in red. Again, if you are buying this at a local drugstore or you already bought a product, it's a really good idea to go over with your pharmacist or your doctor maybe at a visit if the herbal supplement is okay for you to take with your stage of chronic kidney disease. Next, I'd like to talk about medications that are prescription or prescribed by your physician. So the first class of medications are diabetes medications, which are very commonly used for those with diabetes to help manage your blood sugar. Some of the diabetes medications may need to be dose adjusted, again, depending on what stage of chronic kidney disease that you have. And then some of them may need to be avoided altogether. A really good example is metformin, or glucophage is the other name for it. Depending on what stage you're at and what your actual serum creatinine is and your creatinine clearance, you may need a dose adjustment or you may need to avoid it altogether. And that is something that you should go over with your doctor. If your kidney doctor is not the one that you are talking to about it, I would remind your primary care physician or your diabetes doctor, your endocrinologist, about what chronic kidney disease stage you are at and to review your numbers with them. There are other alternatives to metformin that could be used safely, again, depending on what stage of chronic kidney disease you're at and where your actual serum creatinine level is. The other class of medications that may be prescription or over-the-counter are heartburn and upset stomach medications. These need to be used with caution or maybe even avoided depending on how they can affect your electrolytes. Again, if you struggle with higher potassium levels because of your chronic kidney disease or magnesium levels, some of the heartburn and upset medications may not be good for you. Again, I would talk to your pharmacist at your local drugstore or your doctor before taking these medications. The next class of prescription drugs is called statins, or cholesterol medications. Some of these may need dose adjustments based on, again, what stage of chronic kidney disease you're at and where your actual serum creatinine number is. So your doctor that's prescribing the cholesterol medication or statin should be reminded about your chronic kidney disease when you are getting that prescription or going over that with them. The last class of medications are really important, and there are many of them. So it's our antimicrobials, which include our antibiotics, antifungals, and antivirals. So normally when we get sick, we go to urgent care, or we see our primary care doctor, or we may even go to the emergency room at a hospital. We're not necessarily seeing your kidney doctor or your nephrologist. So we have to remind each other. So as a patient, you remind the doctor that you're seeing at urgent care or the emergency room that you have chronic kidney disease. And the importance of that is when you're getting an antibiotic or when you're getting an antiviral, for example, like Tamiflu, when you have the flu, we need to look at what dose we're giving you. And we may need to cut your dose back and give you less dose and less often. So it's a really good reminder to always talk to your doctor when you're not feeling well, when you have the flu or you have a bacterial infection, and getting antibiotics or antivirals or antifungals, that you do have kidney disease. And then we can re-look at your numbers and then go over the dosing that's appropriate for you. The next thing I'd like to talk about is taking your medications, and we refer to this as medication compliance. Sometimes we talk about medication adherence. It's really just, the bottom line is taking your medications as your doctor has prescribed. So here I have a couple of samples of different pill boxes. These are just examples of what is out there. There's many different forms. This is just to help stay organized. This goes from Saturday to Sunday, AM, PM doses. You can put your pills in here as a reminder of what you need to take day to day, and it helps you stay on track. This one is just a little bit more compartments to break it down even further. Again, it's the day of the week, 7 days, and then it breaks it down from morning, noon, night, and a backup slot. The nice thing about this one is you can pop out a row and you can take it on a road trip. Let's say you're just going to be gone for 2 nights and you just wanted to take 2 of these rather than the whole box. That's there as a convenience thing where you can pop these out. There's many different versions of pill boxes, but I would encourage it as a way to stay on track to take your medication on a daily basis as prescribed, and to avoid missing doses. There's also mobile apps that you can put on your phone, your tablet, your laptop, your computer as reminders, and I'll go over a couple of those in a little bit as well. Here is a screenshot of a couple of free applications that are available. The first one is called MediSafe, and the other one is called Pill Reminder. And we'll go through some of the screenshots of how that could also help you with your medication adherence or taking your medications as prescribed by your doctor. But the next thing I'd like to go over actually is another handout that you have in your packet, and that is just a sample of a medication list here. And this is actually very important. So I'm sure most of you, when you go to your doctor's office or urgent care or the emergency room, you're often asked what medications you are on. So this medication list is an example that I want to go over to help you stay organized of what you actually take on a regular basis. And that it's up to date. So it's a list that you currently take, and it's not a list from 5 to 10 years ago, for example, that you no longer are on. So the first couple boxes here are about, again, the date updated and your general information. So if you were to be found unresponsive by an ambulance or the EMTs coming to your house, and you couldn't communicate to us right away, we actually would have some of this information from your medication list to help identify you, to help emergency contact people, get your pharmacy name, and that's the whole point of having all this information on your sheet. I will like to point out that your medication list, actually, if you keep it with your medications either in your home or where you live, as well as maybe on your refrigerator, if emergency services were to come to your house, so if the EMTs were to come with the ambulance in an emergency situation, they will often look at your refrigerator, as well as they will do a quick look of your medication bag or box or cabinet, and they will try to sweep as much as they can up very quickly. If your medication list is there, they'll bring it with you to the hospital or emergency room, and that will greatly help us, especially if there's no family member with you or caregiver and we could not communicate with you. So that's one good thing that I like to point out. If you could do that, that is helpful. The other thing before I get into the medication list is oftentimes nowadays people live electronically, where they use their cell phone, their tablet, or the computer. And one nice thing to do with this medication list is you can actually take a picture of it, and you can have it electronically that way, and you can share it with other family members, caregivers, and they could share it with us, again, in the hospital setting if we were to need that and we could not communicate with you at the time. Okay, getting back to the medication list, the next section on there is allergies. That's really important because In the healthcare team, we wouldn't want to give you anything that was bad for you in terms of you having an allergic reaction or that you couldn't tolerate a medication. We wouldn't want to challenge you with that again if we already know you had difficulty or problems with it. An example here is penicillin, which is an antibiotic. An example of a reaction is a rash that you got from it. And so we would try to stay away from that as much as possible when giving you medications that you may need. The next breakdown is just going over the main part of the medication list, and it includes trying to be as complete or specific as possible. So the date that you started a medication, the name of it, the dose, and how you take it. And then if you also know the reason for taking it, that's also helpful. So as you can see here, the first line is very complete. So calcium acetate is the first medication listed there. The dose is listed there, how often you take it, and it's usually used for high phosphate levels. The second line there is an example of not being complete, where you have Docusate 100 milligrams. We don't know how much you take or what time of day. If you just take it as needed, we still would need the dose of how many of the Docusate you take. There it's showing you a little bit more complete dosing of Docusate 1 daily as needed. The next line there again is an example of another medication used for blood pressure, lisinopril, but the date that you started there is not there. So maybe you started lisinopril 5 years ago, or maybe you just started it last week. It's really good for us to know if it's a new medication you've been on or on it for a long time. There's further examples here which I won't go over. I think you get the point, but we do like to see your medication list as complete as possible and that it's updated frequently. The next thing I'm going to cover is the applications, as I was saying, that you can use electronically to store your medication information. So going over the MediSafe and pill reminder, again, these are just screenshots that you can use from these applications to keep track of your medications. The name of it, the dose, and it can go over your weekly adherence. So Monday through Friday, if you took all your doses or if you missed any, it can keep track for you. Again, these are just different screenshots, again, of helping you keep track of your medications and if you took them as prescribed on a daily basis. And the last thing I'd like to talk about is vaccinations and why are vaccinations important. It's to help us prevent or be proactive, preventative medicine is what we like to call it. And as you have chronic kidney disease and you go through the different stages of it, you're actually at more risk of having infection that can often lead to hospitalization, which we don't want. So in general, for all stages of chronic kidney disease, we do recommend the influenza vaccine every year, so annually. That is to help prevent the influenza virus, or to also help maybe minimize, if you were to get the flu or influenza, minimize the severity of it, or how bad it is, and the length of how bad you have that viral infection. So again, for all stages of chronic kidney disease, that is recommended every year. And for adults with chronic kidney diseases stages 4 and 5, the vaccine that's recommended is the pneumococcal vaccine, which helps prevent pneumonia, as well as the hepatitis B vaccine. And that's usually required if you were going to be considering dialysis at a dialysis center. They would want you to be vaccinated with that before going into a dialysis clinic setting. The nice thing about vaccines nowadays is that you could get them conveniently at a local drugstore. You don't need to go to your primary care physician or physician's office for it. And most vaccines or vaccinations are also covered by most insurances as well. So it's pretty inexpensive, even if there were a copay for you to pay. One of the last things I'd like to talk about is Another barrier to medication adherence, as we all know, or I know as well as a pharmacist, is the cost of medication. So here on this screen is information actually from the National Kidney Foundation. And on their website is where this screenshot came from. It's called the WaterTree National Kidney Foundation Drug Discount Card. And I have a little sample here of it. This is also the same thing listed here on the screen. And the nice thing about going to this website is you can actually get the card printed at home, texted to you, emailed, or you can get the card mailed to you as well. And the nice thing about this card and why I'm talking about it is it never expires. You don't need to have any activation of it. You have unlimited use of it. It really can cut your drug cost or your medication cost at your local pharmacy, especially if you are uninsured, you have no insurance, or you're underinsured and you have a gap in how much your drug coverage is covering for the cost of your medications. Unfortunately, it does not work for you if you already have medication coverage or drug coverage for your medications, but it won't hurt to have a card like this on file at your local pharmacy if you were ever to need it. Again, it doesn't expire. You can hand this to your pharmacist. They can put it on file for you. And if you were to ever need to tap into it, it could help cover or significantly discount the cost of your prescriptions. So I would encourage you all to either go online or we can also give these to you as well in your packet, or you could ask for one and that can be provided for you as well. Again, it's free and it will never hurt to actually have it on file for you to help you save some money on your prescriptions if you were to need it. With that, I thank you for your time and your attention today.
Hi, my name is Rose, and today I'm going to be talking about end-stage renal disease treatment options. It's important to think about things before you choose your options. Things to consider are your daily schedule, other health conditions, your travel, work or school obligations, your social life, and if you have a care partner. Dialysis treatment options, there's 3. There's in-center hemodialysis, at-home peritoneal dialysis, and at-home hemodialysis. Non-treatment options are just getting a transplant and palliative care, where you don't do any treatment and are going through comfort measures. Now, both dialysis options, hemodialysis and peritoneal dialysis, both remove excess fluid and waste from the body. Hemodialysis is done in the clinic in a dialysis facility, and it can also be done at home with training. Peritoneal dialysis is one of the modalities that can be only done at home. We're going to talk about hemodialysis, and it has to do with blood. It's cleaned by an artificial kidney on a dialyzer and a machine. The tubing that's on the machine allows blood to flow from your body to your machine and back to your body. There are 2 needles. They are required for each treatment. If you have a fistula or graft, one of those needles will remove the blood and one will return the blood. And only a small amount of blood is taken out of your body at any time. In order to do hemodialysis, you'll need accesses. A hemodialysis access actually takes time for it to mature. You need needles and an access to deliver the blood back and forth from your body. The first choice is a fistula. It's a surgical connection of your artery and your vein, and it takes 2 to 3 months to heal, so it cannot be used right away. A graft is your second choice. It's a surgical incision of a special tube, which is used like a vein and takes 2 to 3 weeks to heal. And because these hemodialysis accesses take time to mature, if you need hemodialysis urgently, you have to use a hemodialysis catheter. A catheter is inserted and it's through the skin and sutured into place in your neck, chest, or groin. It's used only for emergencies and when urgent dialysis is needed. It's temporary, it needs to heal, it must be kept dry, and there's a higher chance of infection, so it's not recommended for long-term use. In-center hemodialysis pros and cons are that the therapy is performed by trained clinicians. They're all medical professionals. There's no equipment or supplies needed at home. There's opportunity for more frequent social interaction with other dialysis patients. The cons are you have to travel to the clinic 3 times a week, and treatments are usually 3 to 5 hours per session. You're on a fixed schedule when you receive your therapy. The diet is more restrictive, and there's a high risk of infection. This dialysis can be done at home, but it has to be done with training and with a care partner. The benefits are you can plan your treatments around your schedule, you will save travel time and transportation costs, and patients feel better and have more energy. And you get to also have more flexibility with your diet. These are pictures of the dialysis systems that can be used. Their NextStage system is what's used. You have a portable cycler, some cartridges and solution that you have to store. So you will need space for all these items. Next, we'll move on to peritoneal dialysis, which also removes toxins and waste using a natural filter that's inside the lining of your abdominal area. It's used with some solution. A bag of dialysate is connected to a tubing that's in your stomach, and then your abdomen will fill with the fluid. Waste and fluids, chemicals, they'll flow through the membrane, and about 2 to 3 liters of fluid are inserted with each exchange. It's left there for a few hours, and you drain it out of your body into an empty bag. You'll need an access for peritoneal dialysis. It's going to be a catheter that you need because you need to flow the fluid in and out of your catheter. The catheter surgically inserted on either side of the abdominal area. The catheter will extend several inches out of your body, and it could be hidden when not in use. There are 2 types of peritoneal dialysis that can be done at home. The main way of doing it is through this machine called a peritoneal dialysis cycler, and it's used at night, every day at night, overnight while you're sleeping for about 8 to 10 hours. Now the backup way is called continuous ambulatory peritoneal dialysis. It's a manual process, no electricity. It can be done in the home and locations at home or while traveling, and it means that you have to do 4 exchanges a day when you do manual exchanges. It's the backup way of doing dialysis when the machine gets broken or there's a problem with the machine. Pros and cons of peritoneal dialysis. A partner is not needed. Most flexible schedule treatment allows independence and a more normal working lifestyle. And just like our kidneys, they work every day. Peritoneal dialysis is every day, and it functions like a normal kidney. It's bloodless, there's no needles. You have a less restrictive diet on fluids because you're getting cleaned every day. Traveling is easier. The cons are it needs to be done every day. There is a risk of infection. It's an external catheter, and you'll need a lot of supplies, so you need storage at your home. And larger people do need more dialysis, so it's based on height and weight. That's the end of this talk. Any questions?
Hi, my name is Kelly. I'm a licensed clinical social worker, and I've worked in healthcare for the past 30 years. The first 24 years I worked in hospitals, in dialysis clinics, and with transplant patients. And the last 6 years I've worked as a kidney transplant coordinator at a local hospital. So today I'm going to talk with you about kidney transplant. In your packet, before I begin though, there'll be several items. There'll be one which is just a general resource list. And when people get sick, many aspects of their lives are impacted. Their employment could be impacted, their insurance, family life, all kinds of things. And so people may need various resources that they haven't needed in the past. And so if you want to review those, one or more or none of those things may be of help, but at least you have them. The other couple of things I have in there are some flyers for some local support groups. There's one support group which is held here in Walnut Creek monthly, and there's another support group which alternates in 2 other counties in the Bay Area. Support groups are a great way to connect with people who know what you're going through, who have sort of forged this trail ahead of you, can provide some helpful insight and information, and you may also be able to help them. So I highly recommend support groups at least a couple of times just to sort of make that connection with people who know what you're going through. And then the last thing that's in there is kind of a cheat sheet for how to present yourself as a strong kidney transplant candidate when you go for a transplant evaluation. And it reviews all of the things that any transplant center will be looking for in evaluating whether you have the support in your life and various other areas of stability that are really important to making this successful for you. So, why choose a transplant? It's important to start out by saying that kidney transplant is a treatment, not a cure for kidney failure. So just like with dialysis, there are things that you need to do, such as treatments and medications in order to make those successful. The same is true with transplant. Some of the benefits and bonuses to having a transplant over dialysis are that you don't have to go to dialysis. You don't have to go to a clinic a few times a week or do those treatments at home. People describe an increased quality of life. They feel better. They feel back to kind of more their normal self. People statistically will live longer with a transplant than on dialysis, so that's important. It's also important to know, excuse me, that it's not for everybody. There are reasons sometimes why dialysis may be a preferable treatment for somebody over transplant, or perhaps transplant isn't the right option medically for them, and dialysis then would be the better choice. So who can get a transplant? So any end-stage renal disease patient with good medical, mental health, and social support can be considered for listing for transplant. That means that when you go to an evaluation, you'll be cleared by a doctor, a social worker, surgeons weigh in financially. There'll be a financial analyst who will have reviewed your insurance information. When somebody gets listed for a transplant, if they're already on dialysis, their transplant waiting time goes back to the first day of dialysis. But for people like you who are not yet on dialysis, it's important to pay close attention to a number called GFR, which I know Britton talked about earlier. If you are not yet on dialysis and your GFR is 20 or lower, you are eligible to be referred and evaluated and potentially listed for a transplant. Why would you do that early? Maybe dialysis is a couple of years off for you. The waiting time in Northern California is very, very long, particularly as comparing to the rest of the country. So the soonest you can get on a transplant waiting list and begin accruing wait time, by the time then maybe that you do have to start dialysis, you already have a good amount of waiting time behind you, and it will shorten the amount of time that you need to be on dialysis. It doesn't mean you're 100% committed to it right now. It just means you are allowing yourself that option should you choose it in the future. So people often ask, how long will a kidney transplant last? So an exceptional transplant can last a lifetime. I've definitely met people whose transplants were 28 years old and still going strong. They don't all last that long, but they definitely can last a long time. The US average for a standard deceased donor transplant is 10 to 12 years. The US average for a living donor transplant is 16 to 18 years. Fortunately for you, you live in an area where all 4 transplant centers in Northern California surpass these averages. We do a better than expected job, and our patients have better than expected outcomes overall. So that's good to know for you being a resident in this area. One thing that is not good and can impact your transplant very negatively is smoking or the use of nicotine at all. If you smoke after transplant, your risk of losing that organ, graft loss, losing the transplant, is 30% increased if you smoke. your risk of a cardiovascular event, such as a stroke or a heart attack, is 114% increased if you smoke after transplant. And your risk of cancer is 91% increased. All patients must stop. That's pretty universal. And certainly around here, it's a must. So the transplant centers in this area will not list or transplant anybody who uses nicotine. It's a little more complicated now because some people are using Juuls or vaping. Many of those contain nicotine and they are not allowed, so no nicotine at all. So where do the kidneys come from? There are two ways that you can get a kidney transplant. One is a deceased donor transplant. So that's typically a young, perfectly healthy person who was in some sort of an accident. They are in an ICU, in a hospital, on life support, and they've been declared brain dead, so they're not going to recover. So that is where the deceased donor organs come from. And their families, during very tragic times, have made the generous decision to share their organs. Living donor transplant is the other option. Most of us born with 2 kidneys. We only need one to live a perfectly normal life. So there are lots of very generous people out there who are willing to donate one of their kidneys to somebody who needs it, leaving them with one and giving the other person the one that they need. People often ask, how safe is my donor? Is it going to be okay having that other person's organ in me? There's always a small chance that a little cancer or a little infection that was missed could be transmitted to a recipient. There's no 100% in any of this, but do know that every organ is screened very, very carefully, particularly for things like HIV and hepatitis. The donor is also scrutinized for any high-risk behaviors they may have engaged in while they were alive. And if it's determined that there was something such as IV drug use that would put them at higher risk for certain illnesses, they have all the normal screening, but that would be disclosed to the recipient. When you got that offer call, they would let you know and let you choose if you felt comfortable with that or not. And if you're not, that's okay. They'll go on to the next person. You don't lose your place in line. So let's talk about living donation. There are, again, 2 different ways you can get a living donor. So a healthy blood relative, a parent, an adult child, a sibling, a cousin. Those are people who we would consider living donors. A living unrelated could be a friend, a spouse, a neighbor, a coworker. We've seen all kinds of amazing people come forward and want to give a kidney to somebody in their life who they really care about. There are advantages and some disadvantages to a living donor transplant. So the advantage is there's a higher success rate. So when a kidney is removed from a deceased donor, it's put on ice. And depending upon how far that kidney needs to travel to get to the hospital where it will be transplanted, we refer to ice time as the amount of time that it's been out of somebody's body on ice before it's in the recipient's body. So you want to minimize that time. And with living donor transplant, there's a donor in one operating room and a recipient in the other. So it's at most an hour that the organ would be out of the body and then into the other person. So that's a benefit, and it helps with success rates. It avoids long waiting lists. The waiting lists, as I said, in this area are long. And the living donor transplants can happen very quickly in a matter of months versus waiting on a list for years. The operation can be planned in advance. We've had teachers who've said, you know, I don't want to miss any time in my school year, so I'm going to plan my surgery for June, give myself a few months to recover, and I'll be back at work in the fall with my students. Or somebody says, I've got this wedding I want to go to, I don't want to have this hanging over my head and worrying about it, I'm going to schedule my surgery for when I get back. Any and all scenarios that make sense for the person. It's in their control when they schedule the surgery. And there's less rejection, again, kind of often related to that ice time. The disadvantage really is that there is minimal risk to the kidney donor. It's not often, but we can never say that somebody going under anesthesia has no risk. It's minimal risk, but there is always some risk. So in terms of compatibility, who can you get a kidney from? So O is the universal donor. An O blood type can give to any of the 4 blood types, and an AB is the universal recipient. They can receive from any of the 4 blood types. The 4 blood types are A, B, O, and AB. We don't care about the positive or negative for kidney transplant. That doesn't factor in. So if you're on a waiting list for a deceased donor, if you're an O, you're going to be on the O list, B list, and so forth. There's no crossing over of blood types, because if they pulled all the O's and were giving them to everybody else, those poor O's would never get a transplant. So for deceased donor, you're just going to get your blood type. But for living donor, there's a little more play and more options. So if you are an A blood type, you can receive from an A or an O. If you're a B, you can receive from a B or an O. If you're an AB, you can get from any of the 4 blood types. And if you're an O, you can only receive from an O. We always tell people, don't rule out your own donors and don't worry about your donor's blood type. We do, all of the centers do paired donations, donor chains. If you have a great donor who's not blood type compatible with you, we can put you and your donor in a swap. So that means all of your information is entered into a database, and they find, oh, look, over here there's a pair, and their donor matches this person, and your donor matches their recipient. That's a straight swap. You just got 2 pairs, and you're swapping donors. The donor chains are things you hear about on the news more often, and that begins with an altruistic donor. So an altruistic donor is somebody who contacts a transplant center and says, hi, I would like to donate a kidney to somebody. I don't have anybody to give one to, but I would like to do that. And once the hospital is determined the person has good reasons for wanting to do this and is of sound mind to make that decision, etc., they can begin a chain. So the altruistic donor gives a kidney to a recipient, and then their donor gives to another person, and their donor gives to another, and so on. And then at the end, you'll have a dangling donor. You'll have one last person here. And so that person will be kind of held, and sometime in the near future, the idea would be that they would then start a new chain. So the bottom line is having a living donor gives you more options because we can look at all these various scenarios for you to get you transplanted sooner. So kidney pancreas. So many insulin-dependent diabetics can receive a kidney pancreas. Different transplant centers have different criteria. For most transplant centers, they want the person under 60 without severe vascular disease. You have to have insurance coverage. Not all insurance will cover a kidney pancreas, particularly for type 2 diabetics. And the weight needs to be within an acceptable range. It's a more complicated surgery. You're getting 2 organs. So there's a much more rigorous evaluation process to make sure that this is safe. The nice thing for these people is afterwards they have a new kidney and they don't have diabetes anymore. So it's a great option for some people. So transplant centers also have BMI requirements, body mass index. And so that's kind of a calculation that looks at your height and your weight and assigns a number. So again, different transplant centers can have slightly different criteria, so you would want to check with the transplant center that you're working with. But for a lot of centers, you would want to be 40 or below, a BMI of 40 or below to be considered for listing, 35 or below to actually have surgery, and lower than that, 30 or below for a kidney pancreas. Again, there is variability among transplant centers, but that's kind of a general rule of thumb. The reason is, and I'm going to talk about this later, but the new kidney goes in your lower abdomen. And so you want to minimize the time under anesthesia. You want to minimize the risk of infection and slow healing after surgery. And so when the doctor's trying to do the vascular connections, it lengthens the time you're under anesthesia because it can be very difficult and complicated. So particularly weight that's carried in the middle, it would be important to reduce that. But again, your transplant center will let you know if you have any weight that you need to lose at all. So this just kind of shows, so here are your kidneys, right? They're about the size of your fist, back up here in your back. And these tubes right here are called the ureters. So this is what the urine goes through. And the ureters hook onto the bladder. Okay? So the kidneys, the ureters, and the bladder. When they take the kidney out of the other person, out of the donor, they take it out with a little piece of its own ureters still attached, and they just hook it onto the bladder with the other two. So the new kidney goes in the left or right lower quadrant of your abdomen, and your native kidneys don't come out. They're not hurting anything, they just don't work. In very rare exceptions do they need to come out, but mostly you end up with 3 kidneys and one is doing all the work. So, as I was saying earlier, so with dialysis, there are treatments that you have to do and medicines that you need to take and a diet that you need to follow. With transplant, there's no special diet that you need to follow. Your liquid is not restricted. You don't have to go to a center for regular treatments, but you do have to take a lot of medication, and you must take it every single day of your life after your transplant. So the way I like to try to describe the immune system, it's like a little army in our body. And when something foreign enters our body, our little army goes after it and attacks it. So a flu bug, you cut yourself, your finger's infected. The immune system's going to move in and try to take care of that and keep us healthy. The problem is when you put somebody else's kidney inside you, your body, that little army, does not know that's there for good. It just knows it's not you. And so its job and what it will do is move in and attack that new kidney. So we give you medication called immunosuppressant medication, anti-rejection medication, which holds that little army back, holds your immune system back just enough to allow your kidney to function and not be attacked and bothered by your immune system. It's a tricky little balance in the beginning, so there's often in the first period of time some adjustments that need to be made with medications to get it right. We don't want to oversuppress you so you catch every single cold and flu out there, but we can't undersuppress you either, or you'll have a problem with rejection. Acute rejection is something that occurs in about 10 to 20% of transplants. It's normally reversible, and it's basically usually in that early time where they're trying to get that balance just right of the immunosuppressant medication. If you have a little acute rejection, you'll need to go back to the hospital. They'll treat you, they'll adjust your medications, and usually it's fine. Again, the anti-rejection medications prevent rejection. They must be taken every single day for the rest of your life. Your immune system will never ever forget that kidney is not part of you. So 20 years down the line, you could have had a great kidney. If you stop taking your medications, your immune system will move in and attack it. It never forgets. The medication is the critical part of this treatment. It's what makes it work. Without the medication, your transplant guaranteed will fail. So you have to take the medications. It's a lot of medications. So here's an example of a pill box, which you'll be given at the hospital when you are discharged. And they'll set it up for you. Some medicines are once a day, a lot of them are twice a day. They'll get it all set up for you because a pill box really is the easiest and best way to manage this. This is an example of a morning dose of medication. It looks like a shocking amount of pills, I know. But after about 90 days, the number of medications is reduced. But if you think about it, you have to take those pills in the morning, you go on with your day. There's nothing else asked of you. So it's a pretty good deal when you compare it to the alternative. So after transplant, You'll be taught in the hospital about all your medicines and caring for your transplant. You'll go home, you'll be assigned a post-transplant coordinator. You'll be getting labs pretty frequently early on, but in your local area, wherever you live. You don't have to come to the hospital for those labs. And the post-transplant coordinator and the doctors are monitoring those labs. Again, looking to make sure the values are right, that there's no concerning change in your lab values. Those lab tests go on forever. They decrease in frequency over time, so you won't be going as often 6 months after transplant as you do in the beginning. The lab is also really, really important forever, because rejection is silent. So you may have had a transplant for a number of years and feel like, I feel totally normal. I know my body. I've had this transplant for a number of years. I'm fine. I don't really have time to go to the lab this month. And that could be a missed opportunity to see that rejection, chronic rejection, is setting in. You want to catch that very early. So the only way often to tell that rejection is setting in is with your lab work. Very, very important. And then clinic visits. So a little bit more often early on, and then less frequent over time. Transplant centers always partner with your local nephrologist. It's a partnership, and so while the transplant center's doing a lot of the work early on after transplant, then the local nephrologist slowly starts to take over more of that over time, and then the transplant center is taking more of a backseat. So 3 important things to help you have a long, successful transplant. Take your medication every single day, always get your lab work when they ask you to, and always go to your clinic visits. So when you go for your evaluation, you'll see a doctor. Usually there's a presentation of some sort that teaches you about transplant at that particular center. You'll see a transplant nephrologist who will do an assessment of your physical health and your history, what's been going on with your health. There'll be a psychosocial assessment by a social worker. I can tell you one of the big areas of focus with every transplant center is support. It's very important that you have a support team in place. So I recommend when you show up to your transplant evaluation that you have the names and phone numbers of at least 2 or 3 people who have said that they would make themselves available as your support after transplant. So that includes things like driving you to the hospital when you get called in, being there for your discharge teaching, driving you home from the hospital, being prepared to drive you back to the hospital if there are any acute rejection episodes, driving you to the local lab early on before you're cleared to drive if you're a driver. Helping make sure you have food and picking prescriptions up and just emotional support. Transplant is not something you can do by yourself. You need other people. So show up to your transplant evaluation prepared with 2 or 3 names and numbers of people, and that will be helpful in your consideration as a transplant candidate. You'll also have additional education by a transplant coordinator. Sometimes people might need to have additional lab work on that day as well. We strongly recommend that people consider double listing if they can. Again, because of the long wait times here, if you can be on more than one list, you're just kind of casting the net wider and giving yourself more options to get an offer. So in our area, California Pacific Medical Center, UCSF, and Stanford are all in one region, and UC Davis is in its own region. So usually what we recommend to people is they pick one of the 3, UCSF, Stanford, or CPMC, and UC Davis. That gives them the opportunity of potentially getting offers for more people. It doesn't help you to be on more than one list in the UCSF, CPMC, Stanford region. Okay? But it's a good idea to consider doing that. Financing transplant, so who pays for this? Insurance is very important. Most people cannot do this by themselves. The medication costs alone, the monthly medication after transplant, if you didn't have insurance, would cost you in the neighborhood of $5,000 a month. So most people can't afford that. So it's really, really important to have Medicare, to have insurance rather. Medicare, Medi-Cal, employer plans, Covered California, there are all kinds of insurances that will pay. your insurance situation will be reviewed by one of our financial analysts at any of the transplant centers, and let you know, do you have adequate coverage, or if you don't, if you'll have kind of a big out-of-pocket expense, what that might be. So you can anticipate and think about, okay, do I need to get an additional insurance, or am I okay, or do I have to change things up a little bit? So it's important that you never let your insurance lapse, that you always keep yourself fully insured. This is just kind of Medicare basics. So when people initiate treatment for end-stage renal disease, if they have worked and contributed to Social Security, they'll be eligible to collect Medicare immediately if their first treatment is transplant or home dialysis, and after a 3-month waiting period for in-center hemodialysis. So whether you have a commercial plan or not, you can have that in conjunction with the Medicare, and the financial analyst will go over all that with you. Medical costs for the living donor are typically covered by the recipient's insurance. So any testing, the surgery, all of that, typically covered by the recipient's insurance. What's not covered is lodging, travel. So if they need to come here from out of state, for example, they would need to figure out how they would pay to get here, where they would stay afterwards as they were recovering from surgery. So those kinds of things are not covered, but the medical part of it is. Really, really important to keep not just the transplant center, but all of your physicians current on any major changes. So if you have a new address, a new phone number, a new insurance. For us, if you have a new dialysis clinic, a new nephrologist, keep us in the loop. If our financial counselors all do a great job of keeping authorizations current, but if we call you in the middle of the night for a transplant and you then happen to mention to us that you've switched to a new HMO and we don't have an authorization for that HMO, we have it for the one that we thought you had, that's a problem. So please keep us current. We will all always do our job to keep authorizations current and on file, but we don't know what we don't know. Likewise, if we have an offer for you, we have a kidney, and we can't find you because all of your phone numbers and contact people, everyone's numbers have changed, you've moved, we can't find you. We have a limited amount of time where we can try to reach you before we then have to go on to the next person in line. So don't miss out on a transplant because you forgot to tell us you have a new phone number. Always keep, and this would be true for all of your doctors, keep everybody informed every time there's that change. Again, the support team, we talked about the importance of this. Okay. Again, important to remember that transplant is not a cure for end-stage renal disease. It's an excellent treatment choice, though, for a lot of people. Patients must be willing to commit to the ongoing medication, lab work, and clinic visits. But what people describe is just increased energy. It's easier to travel. They can eat and drink what they want. They feel like they have a more normal life. And so those are some of the really huge benefits to having a transplant. So if you do your part and take really good care of that kidney, you have reason to expect that that kidney will do right by you. Okay? So thank you for listening.